You know, there is this classic aphorism in medicine. It's something professors, they hammer into the brains of first-year medical students until they can recite it in their sleep. It goes, when you hear hoofbeats, think horses, not zebras.
It's a survival mechanism, really. I mean, it basically means common things are common.
Right.
If someone comes in with a runny nose during flu season, it's probably the flu, not, some rare tropical fever. It stops young doctors from ordering million-dollar workups for every single cough and sneeze.
Exactly. It's a rule of thumb to keep you sane, to keep you grounded. But
Yeah.
today we are going to be a little bit rebellious. We are taking that advice, crumpling it up, and throwing it right out the window.
Yes.
Because today we are actively hunting for the zebra.
And honestly, based on the stack of research we have on the desk today, in some cases, we aren't just looking for a zebra. We are looking for a unicorn.
A unicorn.
A very dangerous, very distinctive creature that breaks almost every rule in the standard medical playbook.
That is the perfect setup. We are doing a deep dive into a topic that, well, it terrorizes medical students on their board exams and definitely keeps surgeons awake at night. We're talking about Medullary Thyroid Carcinoma, or MTC for short.
NTC.
Yeah. Now, I want to address the elephant or the zebra in the room immediately. If you look at the raw statistics, you might ask, why should I care? This cancer only makes up, about 5 to 10% of all thyroid cancers?
Which makes it a distinct minority, a very small slice of the pie.
Right. But as I was reading through these sources, it became incredibly clear that this 5% carries a massively disproportionate amount of weight. It's like the small hinge that swings a very big, very heavy door.
That is a great analogy. You have to understand the other 90% of thyroid cancers, the papillary and follicular types, they tend to be, polite.
Yeah.
I mean, cancer is never good, but those types generally follow a predictable set of rules. They grow slowly, they stay local for a long time, and we have excellent treatments for them. Medullary thyroid carcinoma is the rogue agent. It doesn't care about the rules, it behaves differently, it spreads differently, and, most importantly, it is driven by a genetic engine that can affect the entire family tree.
And that genetic engine is really the mission of this deep dive, isn't it? We aren't just talking about a lump in the neck. We're going to decode the inseparable link between this specific cancer and the MNN syndromes. Multiple Endocrine Neoplasia.
You literally cannot separate them. If you try to treat MTC without understanding the MNN syndromes, you are walking into a minefield blindfolded. There are traps here, surgical traps, diagnostic traps, where if you follow the standard thyroid cancer protocol, you could actually kill the patient.
That is a terrifying thought, but it's exactly why we're here. We need to move beyond just, rote memorization. We need to understand the why. Why does a neck tumor cause diarrhea? Why do we care about the adrenal glands? And why does looking at someone's lips sometimes tell you they have cancer?
All very valid questions. And to get the answers, we have to start at the very beginning. We need to go back to the embryology, the origin story of this tumor, because that is where the rebellion begins.
Okay, so let's unpack this rogue agent. When most of us picture the thyroid gland, we think of that butterfly-shaped organ in the neck that controls metabolism. It uses iodine, makes thyroid hormone, keeps our energy levels up.
Yeah.
Simple, right?
That represents the standard view of the thyroid factory floor. The thyroid is primarily made up of follicular cells. Those are the factory workers. They grab iodine from your blood, they process it, and they churn out T3 and T4 hormones to regulate your metabolism. When those specific worker cells go bad or mutate, that's when you get papillary or follicular carcinoma. But hiding amongst those millions of factory workers is a completely different population.
The sleeper agents.
Essentially, yes. They are called parafollicular C cells. And here is the core fact that changes everything about this deep dive. Medullary thyroid carcinoma does not arise from the follicular workers. It arises from these parafollicular C cells.
And these C cells aren't even from the same neighborhood originally.
No, they are immigrants. Embryologically, they are derived from the neural crest.
The neural crest. Now, for those of us who haven't opened an anatomy textbook in a decade, that means they are basically, cousins to nerve cells?
Correct. During fetal development, neural crest cells migrate down from the top of the neural tube and scatter throughout the body to form different things: pigment cells, parts of the adrenal gland, and nerves. Some of them get off the bus at the thyroid station and decide to stay. They become the C cells. And because they are neuroendocrine cells, they don't behave like thyroid tissue, they don't care about iodine, they don't make metabolic hormones.
So they're basically tourists who decided to live in the thyroid but refuse to learn the local language.
That's a fantastic way to put it. They are neuroendocrine outposts in an endocrine gland.
So what do they actually do when they're behaving themselves?
Their main job is secreting a hormone called calcitonin. Now, in a healthy person, calcitonin helps regulate calcium levels, mostly by telling the bones to hold on to calcium. But in humans, it's actually a very minor player. You can live completely fine without it.
Okay.
But when you have a tumor made of C cells, a medullary carcinoma, that calcitonin production goes haywire.
It goes from a whisper to a scream.
Exactly. And that brings us to our first major clue for the detectives out there. In MTC, calcitonin becomes a vital tumor marker. If you suspect this cancer, or if you want to know how much cancer is in the body, you measure the calcitonin in the blood. It correlates directly with the tumor burden.
But the sources mention something really visual about this too. It's not just floating in the blood. The calcitonin leaves a physical mark inside the tumor itself.
This is one of those classic medical board exam facts that actually matters in real life. The tumor produces so much calcitonin and its precursor, procalcitonin, that the protein machinery can't handle it. The proteins start to misfold and clump together. They form these insoluble deposits called amyloid.
Amyloid. We hear that word with Alzheimer's too, right? Is that a similar idea?
Similar concept, different protein. In the thyroid, this amyloid forms a stroma or a matrix between the cancer cells. So when a pathologist looks at a biopsy slide under a microscope, they don't just see cancer cells, they see these solid nests of tumor cells surrounded by this pink amorphous junk.
And I believe there's a special trick they use to see it, a special stain.
Yes, the Congo red stain. If they stain the slide with Congo red and look at it under polarized light, the amyloid glows with an apple green birefringence.
Apple green birefringence. That sounds strangely poetic for something so deadly.
It is the smoking gun. If a pathologist sees that apple green glow in a thyroid tumor, it is medullary carcinoma until proven otherwise. It tells you immediately, this is not the garden variety cancer, this is the zebra.
Okay, so we have this rogue neural crest cell hiding in the thyroid, pumping out calcitonin and making amyloid. The big question then is, who gets this? Is it just bad luck? Did you stand too close to a microwave? Or is it something else?
It's a mix, and understanding the split is absolutely critical for clinical practice. About 70 to 75% of cases are sporadic.
Sporadic, meaning random.
That means it's just a random mutation in that specific patient. Bad luck. No family history.
Okay, so the majority are random. That's somewhat comforting, I guess.
Well, hold on. Because the remaining 25 to 30% are familial. They are inherited. And in the world of cancer genetics, a 25% inheritance rate is enormous.
That is huge. Usually we talk about, 5 or 10% for things like breast cancer genes?
Exactly. And that is why MTC is considered the high-yield area for genetics. Because if you identify that familial link, you aren't just treating the patient sitting in front of you. You are potentially identifying a ticking time bomb in their children, their siblings, their parents, even their cousins.
And this is where that one specific gene comes into play. The RET mutation.
The RET proto-oncogene. If there is one acronym to take away from the genetics section today, it is RET. RET. It's located on chromosome 10.
What does RET actually do when it's not broken, when it's working normally?
Think of the RET gene as the blueprint for an on-off switch on the surface of the cell. It's a receptor. When it gets the right signal, it tells the cell to grow and divide. When the signal stops, the switch turns off.
And in MTC.
In familial MTC, there is a gain-of-function mutation. The switch is stuck in the on position.
Deliberately on.
The cell thinks it's getting a constant green light to divide, divide, divide. It never rests.
So it's like a gas pedal that's welded to the floor.
Precisely. And because this is a genetic mutation in every cell of their body, that gas pedal is stuck down in other tissues too, not just the thyroid, which is what leads us straight to the MEN syndrome.
Right. But before we get to that complex web, let's talk about the person sitting in the doctor's office. How does this actually look? I mean, usually thyroid cancer is just a lump.
Yeah.
You find a nodule while you're shaving or putting on a necklace.
For medullary carcinoma, that is still the most common presentation. A painless, firm thyroid nodule. Maybe some early cervical lymphadenopathy, which is just fancy speak for swollen lymph nodes in the neck. But because this is a neuroendocrine tumor, it can do things that a standard thyroid lump cannot.
This is where it gets really interesting to me. The symptoms that seem totally unrelated to the neck, the aha moments.
Right. Remember, these cells are factories. They secrete high levels of calcitonin, but they can also secrete other active substances like prostaglandins, serotonin, and something called VIP, vasoactive intestinal peptide.
VIP sounds important.
It is for your gut. These chemicals travel through the blood and hit the digestive system. The classic symptom that sets MTC apart is diarrhea.
Diarrhea. From a neck tumor.
It sounds completely counterintuitive, but we aren't talking about a little upset stomach. This is chronic, unexplained, watery diarrhea. The tumor is chemically forcing the gut to speed up and dump water.
So if you have a patient with a thyroid nodule who also mentions they've had diarrhea for 3 months that just won't go away,
Yeah.
you shouldn't just send them to a gastroenterologist.
No, you should worry about their thyroid. That diarrhea suggests the tumor load is significant enough to cause a systemic hormonal effect. It is a key differentiator. Papillary thyroid cancer doesn't give you diarrhea.
And there's flushing too, right? Like turning red.
Yes, facial flushing, similar mechanism. The hormones cause the blood vessels in the face to dilate. It can mimic something called carcinoid syndrome.
It really highlights how this is a whole body disease just disguised as a neck lump. Now let's talk about how it moves. You mentioned swollen lymph nodes earlier. Is that just a late stage thing?
Unfortunately, no. And this speaks to the aggressive nature of MTC. Unlike some cancers that stay contained within the thyroid capsule for a long time, years, even MTC likes to move. It is a very specific mode of spread.
Where does it go first?
It loves the lymphatics. Early lymphatic spread to the cervical lymph nodes is very, very common. In fact, studies show that more than 50% of patients already have lymph node involvement at the time of presentation.
Wow. So by the time you feel the lump, it is likely already jumped ship to the nodes next door.
Precisely. It usually hits the central compartment first, the nodes right around the trachea, and then moves laterally to the side of the neck. And in later stages, it goes for hematogenous spread.
Spreading through the blood.
Yes, and that's when it hits the liver, the lungs, and the bones.
Which is obviously a much darker prognosis. So to catch this, we have our toolkit. We can feel the neck, we can do an ultrasound. But based on the biology we discussed, the blood work must be different too.
It is distinct. We check serum calcitonin, which is the most sensitive marker. We also check serum CEA, carcinoembryonic antigen.
And what about sticking a needle in it? The FNAC.
Fine needle aspiration cytology. It is the gold standard for thyroid nodules. You take some cells out and look at them. It can be suggestive, especially if they see those amyloid deposits we talked about. But here is the golden rule, the absolute non-negotiable step in the diagnostic flowchart.
I think I know where you're going, the genetics.
Yes. RET mutation testing is mandatory for all patients diagnosed with MTC.
I want to pause on that. All of them. Even the, say, 75-year-old grandmother who seems to have a totally sporadic case.
All of them. Because you cannot tell by looking at someone if they have the germline mutation. Even if a patient comes in with no known family history, there is a chance they are the index case, the first person in the family to manifest the mutation. Or maybe their parents had it but died of something else before the cancer developed. You just cannot skip this step. The risk of missing a familial connection is far too high.
And if you find that mutation, you aren't just treating a patient, you're treating a family. Which brings us to the most complex part of this puzzle. The MEN syndromes. NMEN, Multiple Endocrine Neoplasia.
It sounds like a mouthful, but let's break it down. Multiple means more than one. Endocrine means hormone glands. Neoplasia means new growth or tumor. So, multiple hormone gland tumors happening at once.
Exactly. And these are inherited in an autosomal dominant pattern.
Which means?
It means you only need one copy of the mutated gene to get the disease. It's not recessive where you need a gene from mom and dad. If one parent has it, there's a 50% chance, a literal coin toss, that they pass it to each of their children.
That is a terrifying coin toss. And when we talk about MEN syndrome, specifically MEN type 2, they are inextricably linked to the cancer we're discussing today.
They are. The source makes a clear distinction here. MEN 1 is a different beast. MEN 2 syndromes are the ones driven by the RET mutation and are characterized by medullary thyroid carcinoma. We divide them into MEN 2A and MEN 2B.
Let's start with MEN 2A. This seems to be the classic version. It is. It's often called the classic triad. Component number 1, the constant in all of this, is medullary thyroid carcinoma. Almost everyone, nearly 100% of people with the MN2A mutation, will get MTC.
Okay, so that's the anchor. What are the other two components?
Component 2 is pheochromocytoma.
Pheochromocytoma. That's a fun word to say, but a not-so-fun thing to have. That's an adrenal tumor, right?
Yes, a tumor of the adrenal medulla. About 50% of M2A patients will develop this, and component 3 is primary hypoparathyroidism, so tumors or overactivity of the parathyroid glands.
So thyroid, adrenal, parathyroid, the unholy trinity of MN2A.
Correct, and we will talk about why that adrenal tumor is so critical in a moment. It's a literal killer if you miss it. But first, let's compare this to the darker cousin, MEN2B.
MEN2B. The source describes this as the aggressive variant.
It is much more severe. It is usually caused by a specific mutation in codon 918 of the RET gene, which makes the tyrosine kinase particularly overactive. You still have component 1, medullary thyroid carcinoma. But in MN2B, it is noted as being particularly aggressive and having a very early onset. We're talking about toddlers or infants developing metastatic cancer.
Wow. And do they get the other stuff too, the adrenal and parathyroid issues?
They get the pheochromocytoma, yes. But here is the strange twist. They usually do not get the parathyroid issues. Instead, they have physical abnormalities that are visible to the naked eye.
This is where the medical detective part comes in. You can sometimes diagnose MN2B just by walking into the room and looking at the patient.
You can. The mutation affects the neural development in a way that changes their skeletal structure. They have what we call a marfanoid habitus.
Marfanoid, like Marfan syndrome.
Exactly. Think of Abraham Lincoln, who many suspect had Marfan's. Tall, thin, long limbs, long fingers, what we call arachnodactyly, hyperextensible joints. But it's not Marfan's, it's MN2B.
And there's something about the face too, right?
Yes. Mucosal neuromas. These are benign overgrowths of nerve tissue. They appear as bumps on the lips, the tongue, the lining of the mouth. They might have thickened, averted eyelids.
So bumps on the lips and a tall, lanky frame.
Right, and often they suffer from severe constipation since birth because the nerves in their gut are overgrown, a condition called ganglioneuromatosis.
This brings us back to that unicorn idea you mentioned. If a patient walks in with a thyroid nodule, and you notice they have bumpy lips and long, thin fingers,
you need to be very, very worried. That is the clinical picture of M2B, and it carries the worst prognosis because that thyroid cancer moves incredibly fast. It reminds us that looking at the patient, examining their hands, their face can be just as important as the MRI.
it's incredible that looking at someone's hands or lips can tell you about a tumor in their neck.
It's the interconnectedness of genetics. The same mutation affects development in different tissues in different ways.
Now, there's a third category mentioned in the notes, FMTC, familial medullary thyroid carcinoma.
Think of this as the mildest form, if you can call any cancer mild. In FMTC, the family has a RET mutation, and they get medullary thyroid carcinoma, but they do not get the other tumors. No pheochromocytoma, no parathyroid issues. It occurs in isolation.
So less complex, but still dangerous because the cancer itself is the same.
Precisely. The challenge is distinguishing FMTC from MN2A. If a family only has thyroid cancer, is it FMTC? Or is it MN2A and the adrenal tumors just haven't shown up yet? That's why genetic surveillance is lifelong.
Okay, so we've identified the rogue cell, we've traced the genetics, we've spotted the symptoms and the physical signs. Now the patient's on the table. We need to treat this. And this, I feel, is where the deep dive really earns its keep, because the treatment for MTC is a minefield of potential disasters if you don't know what you're doing.
It is a surgical battlefield, and the strategy is completely different from other thyroid cancers. You have one real shot at a cure, and that is the initial surgery.
Let's start with the main weapon, surgery.
Surgery is king here. Chemotherapy and radiation have very limited roles. You have to cut it out. The primary treatment is a total thyroidectomy. You take the whole gland.
No half measures, no lobectomy, no just taking the lump.
Absolutely not. You need to remove the entire organ. But remember what we said about the lymph nodes?
It spreads early.
Right. So because lymph node spread is so common and happens so early, often microscopically before you can see it on a scan, surgeons cannot just take the thyroid. They must perform a prophylactic central compartment neck dissection. That's level 6N for those keeping track of anatomy.
So they're clearing out the lymph nodes around the trachea and the voice box, basically assuming there is disease there even if they can't see it.
Correct. It's a scorched earth policy for the central neck. And if there is evidence on ultrasound that the lateral nodes, the ones on the side of the neck near the jugular vein, are involved, they add a modified radical neck dissection to clear those out too.
Okay, so cut it all out. That seems straightforward. But here is the trap, the radioactive trap. I feel like for most thyroid cancers, the next step is automatically radioactive iodine.
It is. For papillary or follicular cancer, after you remove the thyroid, you give the patient a pill of radioactive iodine. Any leftover thyroid cells, which are hungry for iodine, gobble it up and get destroyed. It's like a smart bomb. It finds the target for you.
Oh.
But medullary carcinoma comes from C cells.
Which, as we established, are neural crest cells. They're immigrant.
Exactly. C cells do not express the sodium iodide importer. They don't have the pump to pull iodine inside the cell.
So if you give a patient with MTC radioactive iodine, what happened?
It just floats around their body, radiating their bone marrow and salivary glands, and does absolutely nothing to the cancer. The tumor ignores it completely.
Zero effect.
Zero. Therefore, radioactive iodine has no role in treating MTC.
That is such a crucial distinction. You're firing blanks.
Or firing live rounds at the wrong target. It highlights why that initial diagnosis, finding the amyloid, checking the calcitonin, is so vital. If you mistakenly treat MTC as a regular thyroid cancer and rely on iodine to clean up the mess, you fail, and the cancer keeps growing.
Now there's another trap, and this one sounds even more dangerous. The pheo-first rule. This sounds like something written in bold red letters in a surgical manual.
It should be tattooed on the arm of every endocrine surgeon. We talked about MN2A and 2B having pheochromocytomas tumors of the adrenal gland.
Right.
Well, let's think about the physiology. What does a pheochromocytoma do? It's a tumor of the adrenal medulla. It acts like a factory for catecholamines.
Adrenaline, noradrenaline, the fight-or-flight hormones.
Yes. It stores massive amounts of these hormones. Now imagine you have a patient with an undiagnosed pheochromocytoma. You don't know it's there. You put them under general anesthesia to remove their thyroid.
The stress of surgery.
The stress of surgery, the intubation, the anesthetic drugs themselves, all of these can stimulate the adrenal gland.
And the factory explodes.
It dumps a massive load of adrenaline into the bloodstream. The patient goes into a hypertensive crisis. Blood pressure skyrockets. We're talking 250 over 140. Heart rate goes crazy. Arrhythmias. They can have a stroke or a heart attack right there on the operating table.
So you're trying to fix their thyroid, and their heart explodes because you missed the adrenal tumor.
Exactly. It is a lethal error. That is why the rule exists and is absolute. In any MEN2 patient, or any patient where you suspect MN, you must rule out pheochromocytoma before you ever touch the thyroid.
If they have both. If they have the neck lump and the adrenal tumor.
You operate on the adrenal gland first. You remove the pheochromocytoma, and even that takes special preparation. You have to block their alpha receptors first to lower the blood pressure, then beta receptors. You stabilize them. Only once the adrenal tumor is out do you go back for the thyroid.
Pheo first. A catchy rhyme, but it's a life or death rule.
It's the difference between a successful surgery and a tragedy.
Now, we've been talking about treating cancer that's already there. But you mentioned earlier that genetics allows us to get ahead of the curve. Prophylactic surgery. This is fascinating to me, removing an organ before it's even sick.
It is one of the true triumphs of modern genetic medicine. We are moving from reactive medicine to predictive medicine because the link between the RET mutation and medullary thyroid carcinoma is so strong, almost 100% penetrance, we don't wait.
We don't wait for a lump to appear.
No. If we identify a child who carries the family's RET mutation, we recommend a prophylactic total thyroidectomy.
Even if the thyroid looks totally normal on ultrasound.
Yes.
Even if their calcitonin is normal.
Yes. Because we know the cancer will come. It's not a matter of if, but when. The goal is to remove the organ before the transformation begins or while it is still microscopic.
That's incredibly heavy for parents, though, to elect for surgery on a healthy child.
It is. Can you imagine being told your beautiful, healthy baby needs their thyroid out, but it saves their life? The American Thyroid Association actually categorizes the mutations by risk level. For the highest risk, usually the MEN2B mutations, we recommend surgery in the first year of life.
Operating on an infant.
Yes, because in N2B, metastasis can happen by age 2 or 3. For high-risk mutations, like typical MEN2A, we usually aim for around age 5. The goal is to get the organ out before the cancer can spread to the lymph nodes. If you do that, you cure them. They take a thyroid hormone pill once a day for the rest of their lives, but they don't get cancer.
That's powerful. It literally prevents the cancer from ever happening.
It does. It's an incredible intervention.
So let's say we've navigated the surgery, whether it was prophylactic or therapeutic, the thyroid is out, the lymph nodes are cleared, hopefully we didn't trigger a hypertensive crisis. What does the aftermath look like? How do we know if we won?
We go back to our barometer, calcitonin and CEA.
The tumor markers.
Right. After a total thyroidectomy, there should be no C cells left in the body, none. So, calcitonin levels should drop to undetectable.
And if they don't, if they stay high?
If there is persistent elevated calcitonin after surgery, it indicates residual disease. There's tumor tissue hiding somewhere, maybe in a lymph node we missed, maybe a micrometastasis in the lung or liver.
And since we can't use radioactive iodine to mop up the leftovers, what do we do? That feels like a very helpless position to be in.
It is the biggest challenge in managing MTC. We call it biochemical recurrence. The blood tells you the cancer's there, but sometimes the scans can't find it. If we can find a structural recurrence on a CT or MRI, a lump in the neck, we go back in surgically. Surgery is always the first choice.
But if it's spread distantly
Yeah.
to the lungs or liver?
Then we rely on systemic therapies. For a long time, we didn't have much. But recently, we've developed tyrosine kinase inhibitors, or TKIs.
How do those work?
Remember the broken RET switch? The gas pedal stuck to the floor? TKIs are drugs designed to jam that pedal. They block the receptor so it stops sending the grow signal. Drugs like cabozantinib and vandetanib. And now we have highly selective RET inhibitors like selpercatinib. They can shrink tumors and keep the disease stable for years.
But they aren't a cure.
Usually not a cure. They are a control measure. They buy time. That's why the initial surgery is so critical. It's your best shot at a cure.
It really emphasizes that you have to get it right the first time.
You do. There's very little room for error.
Okay, we have covered a massive amount of ground here. We've gone from a single rogue neural crest cell to a genetic family tree to a high-stakes operating room with adrenaline spikes. Let's try to bring this all together for the listener. If you had to distill this entire deep dive into a few key pearls, what would they be?
Okay, I'd break it down into 5 key pillars. First is biology. Remember that MTC comes from parafollicular C cells. That explains everything. It explains why they don't take up iodine, and it explains the calcitonin and amyloid markers.
MTC equals C cells. Got it.
Second is genetics. The RET mutation is the driver. If you see MTC, you must test for RET. It is the gateway to diagnosing M and N syndromes.
Right, test everyone.
Third is the syndromes. Know the difference. NN2A is the triad of MTC, pheochromocytoma, and parathyroid. MEN-N2B is the aggressive unicorn with the physical signs, the neuromas, and the marfanoid look.
Fourth is treatment. Surgery is king. Total thyroidectomy plus central neck dissection. Radioactive iodine is useless.
And finally, the golden rule. Always rule out pheochromocytoma before surgery.
Pheo first. It's catchy and it saves lives.
It does. It absolutely does.
You know, when we started, I called this the zebra. But looking at the big picture, this deep dive really illustrates the power of genetics in modern medicine. We aren't just treating a lump anymore.
No, we aren't. We are moving from reactive medicine treating a tumor once it causes pain to predictive medicine. We are looking at a systemic, inherited pathway where a simple blood test for the RET gene can trigger a surgery that saves a 5-year-old from developing cancer 20 years later. That is profound.
It changes the definition of a patient from a single person to an entire lineage.
Exactly. It forces us to think broadly, to not just look at the organ, but to look at the whole human being.
And I love that unicorn thought you ended on in the notes. If MTC is the zebra, MN2B is the unicorn. Rare, distinct, dangerous.
It reminds us to be observant. In a world of high-tech scans and AI diagnostics, sometimes the most important diagnostic tool is your eyes. Looking at a patient's hands, noticing the bumps on their lips. Those physical traits can tell you more about the thyroid than feeling their neck ever could.
Connecting the dots, that's what it's all about.
Always.
Well, that wraps up our deep dive into the fascinating complex world of medullary thyroid carcinoma and MN syndromes. It's a reminder that in medicine, the exceptions to the rules, the zebras and the unicorns, are often the most critical things to learn.
Keep looking for those zebras.
Thanks for listening, and we'll catch you on the next deep dive.